The recording will be posted on the committee's webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the Primary Care Committee email inbox to send updates or questions. And if you are not a member of the committee, please turn your camera off at this time if it is on. Now I will turn it over to Chair Dr. Judy Zersenthal to call the meeting to order.
Perfect, thank you. Good morning, or I guess good afternoon. It's been a long day already. It is now 2:06 p.m. and I call the April 25th meeting of the Advisory Committee on Primary Care to order. Thanks for being here. I am gonna start with an overview of the agenda. Next slide. We'll start with roll call and then we will vote to approve the meeting summary for the February committee meeting and also for the November one, which has not yet been approved. We missed that one the last time. Then we're going to open the floor for public comment. I am then going to talk about a quick rundown of our timeline for deep diving into each of these 7 policy recommendations and some of the plans about how we're going to bring recommendations to the cost boards. Next is Shane from the Center for Evidence-Based Policy on the topic of patient engagement. We heard a little bit of a presentation on patient engagement already from Department of Health, but Shane's going to provide us with more information on the policy and background to consider. We are also going to hear from Laura from HCA, who's going to walk us through some patient engagement efforts that HCA is working on. After that, Shane's up again. He will provide us an overview of another policy recommendation measuring primary care expenditure targets on a PMPM basis. We have some time built in after each presentation for some questions and discussion. And then after all those, our meeting will be done. So I will start with roll call. And I'm going to call on people by the first name in the order listed on the agenda, which is alphabetical by last name. When I call on you, please unmute your microphone and let us know you're here and then go on mute again. So Crystal?
Here, thanks.
Great. Sharon Brown?
Here, thank you.
Thanks. Tony?
I'm here, thank you.
Hello. Michelle? Tracy? David, who I think is going to be late today, so we'll see. DC?
Yes, here. Thanks.
Great. Sharon Eloranta? Greg?
I am here.
Hello. Chandra?
I'm here.
Great. Meg? Cheryl?
Hey, here.
Welcome. Lon?
Good afternoon, I'm here.
Excellent. Katina?
I'm here.
Mandy? I think she might be out today too. Jonathan?
I'm here.
Hello. Sarah? Linda? Sean?
Here.
Hello. Stacy?
Yep, I'm here. Thanks.
Perfect. Ginny? And Maddie?
I am here.
Excellent. So I'm going to turn it back over to Rochelle, who will facilitate review of the February and November meeting summaries. Take it away.
Thank you, Judy. If you will all please turn your attention to the February meeting summary and the meeting materials. Just a reminder, the recording of the last meeting is posted on our webpage for your reference. Is there any discussion of the February meeting summary or proposed changes at this time for the February meeting summary? And if not, would someone like to make a motion to accept the summary?
DC, I had one minor correction to the meeting summary. I think that 4.5 billion healthcare expenditure, probably supposed to be trillion.
Sorry, what section was that under?
It's in where it's yeah, right there.
Oh, okay, thank you. We will make that change. And,
With that, I would move acceptance.
okay, is there a second with that change?
Second.
Cheryl Morelli, I'm happy to second.
Thank you. All in favor, say aye.
Aye.
Great, thank you. Okay, now we will turn our attention to the November 2023 meeting summary, which has not yet been voted for approval, as Judy indicated. Is there any discussion of the meeting summary or proposed changes at this time? If not, would someone like to make a motion to accept the November 2023 meeting summary?
This is Katina, so moved.
Is there a second?
This is Maddie. I'll second it.
Thank you. All in favor, say aye.
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 Thank you. So both meeting summaries have been approved. And I will open it up now for public comment, which started at 2:10. So looks like we're right on track for that. If a member of the public wishes to provide public comment, please raise your hand at this time. When you're called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. And please remember that this is the time for public comments. Any questions or discussions later is only for the committee members. So we're going to monitor to see if there are any public comments at this time. I don't see any hands. Do you see any? I don't see any hands raised at this time, Judy. So I think we can move on to the next section because we've passed the time for public comment.
Okie doke. So I want to provide you our, as you may have recognized, our timeline and our working on this has changed a little bit. And so as you may remember, we have 7 policy recommendations that we've selected to move forward on for the legislature. Today, we're going to be hearing on 2, patient engagement, which we heard a little bit about already, and on measuring primary care expenditure targets on a PMPM basis. In May, we're going to talk about the remaining 3 that we haven't talked about yet. So recommendation 1 about increasing primary care expenditures. Recommendation 2, increasing Medicaid reimbursement to be no less than 100% of Medicare. And recommendation number 6 of measuring and incentivizing primary care expenditures that align with higher healthcare payment learning and action network APM framework. So after the May meeting, we're going to send out packets of homework to all committee members that is going to provide a very high level assessment summary of all 7 policy options that we're considering. We will ask you to review those and send back via email any additional policy options to consider, any changes or things that you might want to tweak a little bit about that so we can incorporate those in time for the June meeting. And our goal I guess, overall is to bring to the Healthcare Cost Transparency Board's advisory committee is to bring primary care recommendations to the cost board at their July meeting so that they can adopt and incorporate them into their legislative report. While I would love to bring all 7, in talking about it and being realistic, I think it's best if we hone our selection to the top 2 or 3 priorities that we recommend for the board and the state to take action on first, and plan for this year. And then next year, we'll talk about which other ones to bring in or sort of where those are, because I think we have a very ambitious and fantastic multi-year agenda of work in primary care, and we need to figure out where to start. So we'll be asking you in the June meeting. We have a little bit of carryover time in case we need to explore any of the 7 options further or talk about that. We'll review all of the 7 policy options in terms of background, recent developments, what other states are doing. And then the Center for Evidence-Based Policy is going to help guide us through a polling process to cast prioritization votes. And that'll help us narrow down and prioritize as a group our top 2 to 3 recommendations. So any questions about that timeline, prioritization, other things you might want to know? And I was looking at my notes, and now I'm a little horrified. I'm glad none of you were in that room with me on the giant screen. But any comments on that? Okay. So with that, I will pass it off to Shane from the Center for Evidence-Based Policy, who's going to walk us through some patient engagement policy options.
Great, thanks very much. It's good to see you all again. You'll hear from me twice today. As Dr. Zirzenthal said, patient engagement is first up. I just want to note, you have heard on this topic before, and you're seeing much more specific examples. Really, the goal with the presentation today is to kind of show the broader suite of options, and then to get to some potentially actionable recommendations at the tail end that would ultimately be voted on in June, as Judy mentioned. So if you could go to the next slide, please. Great, thanks very much. So by way of issues and background, the first point here is really just illustrating that everyone has a role in patient engagement. It's not just about the interaction between a provider and the patient. And there's strategies that really support patient engagement at all levels. So employers, insurance carriers, providers, and patients really do all have a role. This role is really about seeking preventive care through primary care and actively participating in one's own care to increase the likelihood of successfully managing a condition at the primary care level. And just to reiterate why patient engagement is even being discussed in this forum here, when our goal is to talk about strategies for achieving a 12% primary care expenditure target, patient engagement is important because it's a driver of utilization, that people need to participate in their care and seek out primary care services in order for there to be utilization to drive towards the 12%. So it's really not just about the positive health outcomes, but it's also a strategic mechanism for working towards the 12% primary care expenditure. If you could go to the next slide, please. So we want to start with one fairly specific example of a recent development in Washington, which is Washington is one of 8 states participating in Making Care Primary. We've all talked about Making Care Primary many, many times, and the reason for that is that it's really quite a big deal, actually, that this is a unique opportunity to align across multiple payers, to bring in additional federal dollars into the state, but also to create a unifying framework to really drive towards with primary care practices. And really a key part of that model is implementing things that really will support primary care engagement. The Primary Care Transformation Initiative I think in the past you've heard of the primary care transformation model, but the initiative is Washington's multi-payer effort to support primary care on an even broader basis, but still aligned with making care primary. And this broader initiative similarly has all sorts of elements in the model that are very supportive of patient engagement, which includes things such as providing culturally attuned care, having the right language supports, things like that. And again, so this is really taking a step back to acknowledge that there are things happening that will support primary care engagement and patient engagement. And all of these things work towards achieving that 12% target. If you could go to the next slide, please. So we're going to talk at a relatively high level about some of the different types of strategies. Kind of the point of this section is really getting back to the earlier points I made, which is that everyone has a role. Employers, payers, patients, and practices, and even the state in some circumstances. And so we're going to talk about what are some of the general strategies used within each of these different types of relationships across the delivery healthcare system. So one is patient incentives and education through insurance carriers. There are lots of examples of insurers providing incentives for patients to visit the primary care provider. There are examples of incentives for patients receiving recommended preventive care. And then it's a very common practice for insurers to provide education to members that emphasize the value of primary care. There's lots of different ways to design each of these programs, and there are all sorts of programs across the country. But again, we're just trying to highlight conceptually across each of these different engagement domains what some of the big picture strategies are. Looking at slightly different dynamics, so looking at provider incentives and support through insurance carriers. So instead of the relationship between the insurance carrier and the patient, this is now looking at the provider lens. Common strategy is offering payment models that support and incentivize ensuring patients receive preventive care. So that's the same bucket as making care primary and the primary care transformation initiative, where it's largely between creating opportunities and payment models between insurance carriers and providers. A different dynamic that supports patient engagement is through employers. They have really a key role. There are examples of incentives for completing annual wellness visits and other primary care engagements. Education is another big piece. Health fairs can also promote engagement with primary care. So employers have a lever that they can pull, and it can be a pretty effective lever. And then lastly, going a little bit meta here, but looking at the interaction or where there are opportunities for the state to promote patient engagement. A key example, it's a relatively recent one actually from Oregon. The Senate Bill 1529 is legislation requiring carriers to assign a primary care provider to enrollees that do not actively choose one within 90 days. And that's essentially just creating a relationship where one hasn't been selected that can create a locus of accountability where the practices can reach out to the patients that have been assigned to them, even if the patient hasn't yet reached out. So kind of the key takeaway here is, again, everyone has a role. There's lots of different strategies that are aimed or that can be effective at bolstering primary care utilization through patient engagement. And ultimately, we're going to have to think through which ones might make sense for Washington, and importantly, which ones might make sense as a committee recommendation. If you could go to the next slide, please. So here we just have a little bit of breakdown on how we are thinking about what the information available says. So specific to patient engagement, the type of data that's available to evaluate the different policies. There's multiple studies that examine the efficacy of different patient engagement and promoting strategies. As you just saw, there's a lot of them and in different actors. And so there's been lots of opportunity for studies to look at different types of interventions. If you go to the next slide. In terms of impacts, I think one thing that's pretty clear is that the evidence base is mixed, but I think not surprisingly so. The reason being that because there are multiple actors and the circumstances in which an incentive is offered are going to vary from situation to situation, you're going to have a mixed evidence base. But I think it's still key to note that there is some evidence that these types of incentives that we talked about, be it incentives that are offered at the insurance carrier level or by employers, that they do produce increases in utilization of primary care services, increases in utilization of screening services. Some studies are showing that that is producing healthier lifestyle choices, reduced clinical risk factors, and ultimately lower healthcare costs for actively engaged members. And the next slide, please. So in terms of effectiveness, this is trying to answer the question of we're trying to identify policies that support movement towards the 12% expenditure target. Additionally, improvement in clinical outcomes. For effectiveness, patient engagement is one element of several that's needed to increase utilization of primary care. We think that it can be an effective one. But also workforce and other access barriers have to be addressed to ensure that there's sufficient capacity for providers to meet increased demand, as might be generated by increased patient engagement through incentives and other policies to promote patient engagement. Next slide, please. Feasibility. There are in feasibility meaning policies that could be recommended by the committee. There's a lot of policy options that really fall outside of what could be required or supported by the state. A really good example is private sector employer mandates. There are a lot of protections on what can be forced on employers to offer to their employees, particularly around healthcare. So there are some limitations there. Additionally, and this is really depending on which specific strategies might be recommended, but political feasibility, this is looking at the example of what Oregon implemented with Senate Bill 1529, requiring primary care provider assignment. It might not have broad support from employers and patients. We don't fully know, but people do tend to like choice. And then additionally, investing funding into initiatives that promote engagement with primary care. If it costs more money, it may not be a priority relative to other pressing needs, despite the potential positive longer-term impacts. Next slide. Thanks very much. Administratively, primary care assignment would require legislation and administrative action by all of the payers. So it's not without administrative burden. And then patient engagement incentives for public employees, which is, by the way, one of the potential areas where you could have a recommendation. It would definitely require setting up program infrastructure and addressing funding issues. Next slide, please. Okay, so this says vote, but this is really thinking through what options you want to have at the table for the vote in June. So what we've tried to do here is to tee up a couple of areas under patient engagement. So based off of some of the high level context today and some of the more specific examples that you've heard in other presentations or will hear, things that could be actionable by the committee. And these really are the straw models. They are straw models with a lot of thought behind them about feasibility and actionability. But ultimately, we want your feedback on these, and that feedback will be used to inform what's presented in the homework and then ultimately voted on in June. So the first recommendation is related to making care primary. it would be a voice of support for HCA's efforts to participate in Making Care Primary and the Primary Care Transformation Initiative, including support for pursuing resources for eligible primary care practices to grow capacity to provide comprehensive whole person primary care. So this is getting back to the what was mentioned in What's New in Washington, Making Care Primary, which you again have all heard about previously quite a bit. It truly does align with the state's efforts for primary care transformation quite seamlessly. And under this framework, patient engagement unambiguously is something that would benefit from all of the different levers being pulled under the initiative and under Making Care Primary. So it does make sense that the committee providing support for advancing these efforts could be a boon to patient engagement, and then subsequently a boon to achieving the 12% primary care expenditure target by virtue of increasing primary care engagement. The second recommendation, and then we'll come back and we can discuss recommendations on how we might tweak the language or look at even other options if that's what you'd like, is that HCA should conduct an opportunity analysis of patient incentive programs that could be implemented to increase engagement with primary care providers while improving patients' health. Promising feasible opportunities should be pursued through the appropriate authority and operational processes. So we've teed up two concepts that lean in on where there appears to be more actionable opportunity in the state that the committee could get behind. I would note that there are a couple of strategies that we talked about that are not listed here that you might consider when you provide feedback. So the first would be what Oregon did essentially. So they passed that legislation, the Senate Bill 1529, that mandated primary care assignment to patients that didn't select one for themselves after 90 days. We also didn't include anything around mandates for private sector insurers to provide incentives to patients, nor did we include anything around commercial payers providing incentive to patients because those are potentially less actionable areas or less politically viable than the two in front of you. But with that, why don't we open up for discussion and get your feedback to the straw model recommendations. If you like the general flavor but have proposed tweaks to the language, that's great. Or if you feel like they're missing the mark, that's great feedback as well. Or if there's something else that you feel like really should be included instead, also great feedback. DC?
Yeah, thanks. And actually, I do have a question that's maybe a little more detail about what Oregon has done. Is that law that was passed, is that targeting public plans only? Or is it attempting to get into the private plans as well, but running into trouble? Or can you describe a little bit further what they actually did or plan to do?
Yeah, that's a great question. And we were actually looking at that again today. We think that it applies more broadly because it does refer to health plans. It doesn't specifically indicate the public, or those that are acting on behalf of the public insurers. But really, it just says that the summary is that they are required to assign within 90 days, absent someone selecting their own primary care provider. So we do think it does apply more broadly, but we can also follow up on that to make sure that that's an accurate interpretation of our statute.
Okay, great. Thank you.
Yeah, absolutely.
Yes, do you think people think that could fly here? Are there not enough PCPs and so it might crash and burn? It would.
Judy, I wonder if there's any evidence that it's even effective.
Yeah.
I mean, just assigning to me is not an effective strategy. And there's a lot of reasons why. Some of them you were already mentioning, in that there needs to be providers with availability to serve. But there's lots of other reasons. So I'm hesitant to even consider whether it would work here until we knew there was evidence that assignment is effective.
Yeah, that's a good question. I know that there are some employer groups that do this. King County was one that we talked to a little bit. They don't have everyone, but for one of their plans, they do this. And they were expecting to get pushback and they didn't get any pushback and people sort of went along with it. So, I think some of it may be, and actually I was just talking with some coworkers today, it is super hard to find an open PCP. And so if someone assigned you, then that's great. You have somebody to start with. On the other hand, if I was that PCP that already had an overfull plate of people, like I wouldn't want more. So trying to sort of
Yeah.
figure out the balance of that and whether it
Yeah.
would be helpful.
Well, I do know of a very large employer not in Washington State who did this, and it went very, very poorly because of the capacity issue. And there was just no way that the provider community could support the so-called assignment.
Right.
And it went the employee feedback to the employer was enormously frustrating because the employees thought that they were going to kind of get something out of this, and that was not. It just was impossible.
Yeah.
So, and I would echo the other thing that you mentioned. It is enormously hard to get any appointment today in the Puget Sound, depending on where you live.
Yeah.
I'm hesitant to potentially make that worse.
Yeah. What do others think about that?
It looks like we have a few hands raised. I see Cheryl has her hand raised.
Yeah, hi. Thanks for raising that. We do this for Medicaid in our state, so they're required. We have PCP, either they pick or we assign, the MCOs assign. So it would be interesting to look at that and see how that's going, right? I think those of us who take care of a large Medicaid population will say it's mixed, right? But I do think we have a large population of patients already that we do this with in the state that we could see, does it make any difference? How often are they changing? The churn's fairly high, but that's because we allow, change every month. So I think there's a population we could request that HCA look at and see if there's anything to learn from the large group of 800,000 that we're already doing this with. That and then my other just like caution is the way just how you deliver this message. If we decide not to go down this road, we do require it for a Medicaid population. So it's okay to require for a Medicaid population, but it's not okay to require for everybody else. So that's, I think it's a caution to be careful in how we talk about this. If this comes up, if this topic comes up, which I think it might. And then ultimately, to be successful in prospective payment models, you do have to know what population you're responsible for and who you're taking care of. So there has to be some way to do that. And ultimately, we do need to get, that's decisions we make today may impact that, for tomorrow for us. So we just need to think about what will our approach be if we're not going to do PCP assignment. There does have to be some way to identify the population you're responsible for.
It looks like we have another hand raised. Crystal?
Yeah, thanks. I appreciate kind of the comments that have been made. I too question whether that would be an effective real effective with the patient. As you mentioned, it does happen in Medicaid, and then those primary care providers that get the assignment, there's questions around attributed members that they can't get in. And so it may put that primary care provider in an awkward situation. And to your point too, then they're held responsible for the quality outcomes, and that access can be really tricky. And then it also seems a little bit disconnected with, I know what we're going to talk about later with honoring that patient personal choice. So it's a little bit out of balance with that, right? Because this is such a tremendous part of that personal choice. It's kind of that first choice they make. So just a couple comments, things to consider. Thanks.
We have another comment from Sean.
Thanks. It's counterintuitive to me to say this, but because I think everybody should have a primary care provider, but in the context of keeping our powder dry for other things, if we want to really focus on a few things to promote, and B, given some of the comments around employers and there's issues around unions and other things, and then C, given the capacity, I'm not sure this is something we want to prioritize. And I think about screening for depression. The U.S. Preventive Task Force says don't screen for depression unless there's something you can actually do about it. And if there's no access, then it's going to be an exercise in frustration. So the concept is sound. The execution, I think, would be extremely challenging right now.
And we have another hand raised. It looks like Lan.
Yes, thank you. Yes, also PCP assignment is a requirement for HMO too. So I think further data will be needed in this regard. I think from a health plan perspective, member perspective, and also provider perspective, looking at data around, what is the definition of, the effectiveness of PCP assignment. But I think from a member perspective, is the view, varying from someone who doesn't know what a PCP is and not really needing care till they need care, right? And then, okay, that's who I go to, versus someone maybe even in the MA population where their PCP is the one who drives their healthcare, and they're basically married to them, right? So I think there's going to be a spectrum of that. And from a pop health standpoint, I do think that being assigned to a PCP does help with driving down ER cost. That's some data that we've looked at from an HMO perspective as well. So I'm in support of that. And I think more data is needed to see if it's feasible for everyone. But I think from a population health standpoint, it warrants us to look into it further. I was also going to say that from a member choice perspective, patients can change their PCP at any time. There wouldn't be a limit to that. And so certainly, being assigned one means that when you need care, and when you need care is different for everyone, that, you have someone that you can call or even ask a question of, right? A team, not necessarily just a person, but a team of where do I go to next? And then and there was a question of access. And I think just being assigned to a provider doesn't mean that you are going to see them. I think that having a trusting relationship with your PCP, also there's advantages to that too, because then, it also helps with access, because there's multiple ways of getting a hold of your team, especially if they already know you and you have that continuity. So.
Thank you for the great commentary. I think the way I'd summarize that is that there seems to be general acknowledgement that there's a potential value proposition there, but there's definitely some barriers in Washington specifically, and potentially generally, that it would take a real clear, demonstrable value proposition to make it even worth trying to overcome some of those barriers. Does that seem like a fair characterization? I'm not sure who I'm asking.
Yes, sounds fair.
Thanks, Stacey. So I think just bringing it back to potential recommendations that we would vote on in June, we didn't include an Oregon-style statutory mandate as part of the suite of potential recommendations. I think in part recognizing some of the same challenges that you raised here. I'm wondering if anyone had reactions to the straw model proposals that we have up on the screen here.
Yeah, hey, it's Cheryl. You won't be surprised to hear me ask this question, but I'm wondering in the first one, primary care practices, what populations are we talking about? Like you know, my bias is that I would like pediatrics to be called out, that they're actually going to be included in any of this at some point. So I would love to see it be a little bit more specific about what populations we're talking about.
Okay, that's helpful feedback. And I
That is
would
why
just
it has the
Oh, sorry.
primary care transformation initiative, because the primary care, and maybe we should, I don't know, we could talk about switching the order of that or moving MCP, you know, off entirely. But you all don't know, but we have been tinkering around the edges and have changed our primary care work from the primary care transformation model to the primary care transformation initiative that encompasses both making care primary and the model group that was there before and sort of whoever else. And it's a little more action oriented. So, but I don't know, making care primary has a lot of, I guess, recognition right now, more than probably our PCTM stuff does. And so, figuring out how to communicate that best is the tricky part.
Yeah,
Is the
maybe it's
poten-
just. Oh, I'm sorry. Go ahead.
Is the potential vote in support of one or the other of these two, or multiple things to support? I think it's hard to give precise feedback without fully understanding the bigger picture.
I don't think that we have actually finalized exactly what that looks like. I think in part because the homework exercise is going to help us shape that and getting through the next discussion. However, to get to the 7, I think you would have to count these two together as a patient engagement strategy that you could vote on.
Okay, thank you.
Any other feedback? Oh, Judy, it looked like you were about to jump in.
I was just going to say, okay, thank you, James, for part 1.
Yep.
And next we are going to move to Laura, who's our Quality and Measurement Improvement Manager from the Healthcare Authority. And she's going to talk about some of our work about engaging patients through shared decision-making here in Washington State. So Laura, take it away.
Thanks, Judy, and good afternoon, everyone. Thanks for inviting me to this meeting. I'm super excited to share with you some of the work that we're doing in Washington State around engaging patients through shared decision-making. So before we get started, we'll just level set and give you the definition for what is shared decision-making, although I'm assuming many of you on the call already know this, but according to the National Learning Consortium, shared decision-making is a process in which clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. So you'll notice certain text in here that's highlighted in red. And for us, that's really what it's all about. It's about patients and providers working together to make decisions based on clinical evidence and patient preferences and values. So next slide. So shared decision-making is not appropriate for every conversation that you have with your patient. It's really only for preference-sensitive conditions. What that means is conditions where there's more than one right answer for treatment options. And there's also a high uncertainty about all options. So it's important that in these types of conversations that the patient is actively engaged and you clearly understand, what's important to them. What are their preferences? What are their values? Here's some examples of some preference-sensitive conditions. Think about joint replacement, spine surgery, medication. Statins is one, diabetes medication is another. There's more than one option, but it's an individual choice about what's right for them. Prostate cancer screening and treatment is one, and then end-of-life care. Do you prefer life-sustaining treatment or hospice? Those are just some examples. So next slide. So why is this important? Well, there's been a lot of research around shared decision-making and the use of patient decision aids. So what that research has showed is that shared decision-making has the potential to improve health outcomes for the patients. The patients are more engaged, actively engaged in their care and their self-management. It reduces variation and health disparities while increasing equity. What we mean by this is it improves underutilization of certain treatment options for certain populations, and while decreasing overuse of certain things. And there's studies that show that it actually increases health equity, and I think I referenced that on a slide that's coming up. And also it supports value-based care as well as population health strategies. So next slide. So why is it important to patients? I mean, it seems pretty obvious, and this is kind of a tongue-in-cheek way to look at it, but it's really true. It really honors the patient's personal choices. So it's important that as a provider, you clearly understand what is important to them. And then which helps kind of support that provider-patient relationship too. It's been shown to increase patient safety, or at least their perception of safety. It supports the informed consent process. So the patients are able, when they make that decision to go take a certain treatment option or not, it's clear to you as a provider that you know what their choice is. It's been shown to improve the overall patient experience, and it's also a key component of patient-centered care. So next slide. So researchers from the Harvard Medical School, on behalf of Picker Institute and the Commonwealth Fund, they defined 8 primary dimensions of patient-centered care. They found that there are certain practices that are conducive to a positive patient experience, and their findings make up the Picker's 8 principles of patient-centered care. So while all of these are important components of patient-centered care, you'll see in red those circles that really get at where can shared decision-making support the clinician-patient relationship. So when you consider opportunities for how clinicians can better inform and educate their patients through shared decision-making, these are 4 principles that help patients and their families, make decisions together with their provider that respects their personal preferences and values. And in addition, I like to include the Institute of Medicine's definition of patient-centered care that, as you can see, includes those preferences and values. So next slide, please. So we make many choices every day. So when you're making choices, some are easier than others, some are more impactful than others. But when it comes to our healthcare, we're also faced with many choices. I would say those decisions are a bit more complicated than maybe where you get your daily coffee fix. And they tend to have more serious implications as well. However, at the end of the day, the decisions that we make are driven by similar things. You can see when you're selecting healthcare, you think about, for health plans, what are the benefits? What's the cost going to be to me? When you're looking for a provider, location is important, and the type of provider is important as well. And then same thing with treatment options. What are the benefits versus the risks? And so when you think about advanced care planning, for an example, what are your options and how do they align with your personal preferences and values? So it all really comes down to what's important to that person, and how are these options, how do they align with those personal preferences and values? So next slide. So when we're making those decisions around healthcare, I think it's safe to say that everyone in this meeting has been a patient at one point in their life. But think about it, how many decisions do you make about your healthcare in a day or in a month or in a year? So there was a study that was done by the University of Michigan for the National Survey of Medical Decisions, and it looked at how patients make a surprisingly large number of decisions related to their healthcare every year. And especially based on your age, as we tend to get older, obviously there's more decisions we need to make. And also 54% of those adults have faced 2 or more of these types of decisions, potentially at one time or not. So next slide, please. So even though we're making all these important decisions, that same study highlights, that we aren't necessarily making fully informed decisions. For example, according to the study, you can see patients on average knew less than half of the critical information needed to make an informed decision. But it's okay, right? I trust my doctor. We have a great relationship. She has my best interest. Well, of course she does, but at least the study showed that at least a third of medical decisions have 2 or more treatment options. And so that's when there's no right course of action. So it's important that the patient is fully informed and makes that decision along with their provider. So next slide, please. So there was another study that was done on the consumer attitudes towards shared decision-making. And so this really highlights how do patients really feel about the decision-making process along with their providers. While this is just one survey, it does illustrate that they want to be an active participant in the decision-making process, with the largest percentage stating they prefer that the patient should decide with some doctor input, followed fairly closely by patient and doctor decide jointly. Next slide, please. So I want to give you a quick overview of what we've been doing in Washington State. The truth of the matter is that shared decision has been around since the 1980s, but we just really started focusing it on a statewide basis around the 2000s. And what happened was in the early 2000s, Jack Wenberg from the Dartmouth Institute, he was doing a study on variation in care. And so he came and presented to clinical leadership and state policy leaders in Washington on how we have clinical variation across regions of our state. So for example, he provided data that showed how someone who lived in a more white, affluent region was more likely to get a treatment service such as total joint replacement, for example, instead of those who maybe lived in the Yakima Valley region. So the response to that information, that data that was presented, was that legislation was enacted to support the use of evidence-based practices to try to reduce variation in care while at the same time not restricting choice. So as well as looking at appropriate utilization based on patient preferences rather than decreasing. Wasn't the idea to go in and say, okay, all you folks in this area, we're not going to offer you these services anymore, but it's to ensure that patients had the right information they needed to help them make the right decision at the right time. And so I mentioned previously that shared decision-making, it's been shown to decrease overutilization, but helps correct underutilization. There's a reference to a study at the bottom that showed when Black men and white men who were faced with the potential, who had osteoarthritis and were given information about what decision they wanted to make regarding, treatment, it showed that when using a patient decision aid, the Black patients, their utilization of these services increased, while the white patients, they actually decreased. So what it did, it leveled out that variation in care. And I know there's been work done by the Washington Health Alliance to also look at that variation in care over the years. So next slide, please. I won't go through all of these, but here's some key legislation that's occurred in Washington. So in 2007, for example, there was legislation that supported providers by doing shared decision-making by giving them higher levels of legal protections when certified patient decision aids were used and documented in the patient chart as a legal record that informed consent has been obtained. So what this means is the burden of proof is higher for patients should something go wrong during that treatment. Although when we talk to most providers about this, that isn't a carrot for them necessarily. They say they do shared decision-making because they think it's important, the important thing to do. And then again, in 2011, I'm sure you're all familiar with the BRIE Collaborative. It was established to promote quality and cost effectiveness through the use of evidence-based guidelines. And then lastly, in 2012, the state legislature gave HCA's medical director the authority to certify patient decision aids using criteria developed by the International Patient Decision Aids Standards Collaborative. That's a mouthful, otherwise known as IPDAS. So next slide, please. So at the Healthcare Authority, we're leveraging our role as the largest purchaser of healthcare in Washington to spread the use of shared decision-making. I didn't really give you a definition of what patient decision aids are, but patient decision aids are tools that providers can use to help patients understand what their options are and understand the comparison across all the options in a non-biased way. There's a lot of patient decision aids out there. Not all of them align with the criteria developed by the IPDAS community, but in Washington State, we have developed a program to certify patient decision aids. I would say it's the only one in the world, probably the universe, but we're plugging along here in Little Washington State, certifying patient decision aids. The importance of certifying patient decision aids is to ensure that they're of high quality. But we also recognize there's a lot of patient decision aids out there that are still very good that haven't been submitted for certification. So at the end of this slide deck, there's some resources, and one of those is for providers how to tell a high quality decision aid, and also how to tell the difference between patient education materials and a patient decision aid. Because there's patient decision aids come in many forms. It could be a brochure, it could be a website, it could be a video. There's a lot of different ways to get that information to the patient when they need it. And the biggest thing is in a way that's non-biased, that doesn't kind of direct them towards one choice over the other. And then we've been promoting shared decision-making and the use of patient decision aids in our role as purchaser in some of our contracts. For example, one of the first things we did with our accountable care program is we incorporated a requirement to do a shared decision-making pilot. This is around maternity care, specifically around VBAC. And there's some fascinating data that came out of there on provider behavior, as well as increase in knowledge of the patients who were faced with those decisions. And so another thing that we've done is we've worked closely with HealthWise. You may be familiar with the HealthWise materials, patient education materials that they've put together. And we worked with them to develop an online interactive skills course for providers. There's no cost, and it includes CMEs. One of the reasons we felt this was important is in our work, we've learned that a lot of providers don't really know what shared decision-making is or how it's different from just having a conversation with the patient. And it is different. And this skills course allows them to practice those skills. And so that is online. There's a link to it at the end of the slide deck. We also worked with the BRIE Collaborative to develop some recommendations for implementing shared decision-making into practice. There's some policy recommendations in there that may be of interest to this group for different populations, for providers, for health plans, for the state, for example. And then lastly, we've been convening statewide discussions around spread and sustainability of shared decision-making and the use of patient decision aids. More recently, we had a in-person workshop in January, and that was our first time getting back together in person since COVID. And it was really great to see all the interest around the state of not only the provider community and the health plan community, but the patient community as well. We had some patient advocates there, and we're going to continue to do that as we can. But in particular, we're in the process of putting together a shared decision-making learning collaborative. The purpose of that is for those who are already doing shared decision-making, and Kaiser's leading the state around implementation of shared decision-making. They've been doing it since in the mid-2000s, and there's other health systems like University of Washington and others who have been doing this, but it's an opportunity for peer learning, for providers and health plans to learn from each other. How can we support the implementation of shared decision-making? How can we support providers to do shared decision-making? We are aware of the barriers. There are a lot of barriers. We know that to be truly successful, it needs to be implemented into the clinical workflow. But we also know that one of the barriers is that there's no mechanism to reimburse providers for shared decision-making right now. There's a couple small ones that CMS has out there, but it's not like in general. How do we incentivize providers to do this? Because on top of everything else they're doing, this is just one more thing, but it's very important. So next slide, please. And those are just the resources I mentioned. So as well as a link right here to our webpage if you want to learn more.
Great. Thanks, Laura. Do people have questions for her? Questions about making this into a recommendation in some way? General comments? Laura knows this is one of my favorite things to talk about. It's so cool.
Me too.
If only
Me
we
too.
had more time in the day
Seriously.
to really do this. Yes.
I know I recognize many names on this call, people that I regularly work with on the performance measure side. So this is my passion project over here. I do like measurement though, but yeah, this is really cool.
Hey, this is Katina, and I can't raise my hand because I'm driving. Just a question about what would this look like in practice? Like, I understand how important shared decision making is, and I love talking about it as well. And I'm just thinking about, okay, the EMR at my institution is not very friendly for anything. I'm thinking, is this one more thing I'm going to have to type? Am I going to have to click a box? Am I going to have to document that I used XYZ certified tool? And like all of the logistics of how does this look for organizations that are already doing this in a way that's getting measured? What would that mean to me in the exam room?
Yeah, that's a great question, and I invite others to jump into who may be doing shared decision making. There's many different ways. There's no right way or wrong way. It doesn't have to be embedded in the EHR. I know some of the larger health systems do have some of the decision aids embedded in their EHR, which makes it really easy for them to it prompts them when they're having certain conversations with their patients. But there's also patient decision aids that literally can just be downloaded and printed from a website or just pulled up. There's some great ones developed by Confluence Health that are available at no cost to providers on screening for breast cancer. You could just pull it up on your laptop if you want. If you're wanting to ensure that you're documenting the informed consent to follow the guidelines of the state law, that's a little bit different. It can be in the patient chart somewhere. There's no standard template for how you document that. You can say, if you have a patient consent form or informed consent form that you use for signature, you can add it to that. But I would say, there's many different ways to do it, but what we've heard most through our pilots is implementing it into the workflow. So everyone's familiar with what it is. They know when it's the right time to use it. And also they can easily access these patient decision aids so they can have that conversation with their patient. I hope that helped.
Yeah, I guess it helped a little. And then I'm still trying to wrap my head around how this kind of feeds into our recommendations. Like, what would the policy recommendation, and how does that tie to our 12% spend? I'm kind of missing, I'm missing a link there. I'm not sure if others are.
Yeah, I'll just start, but welcome others to jump in on this. I do know that there are some proposed recommendations through the BRIE Collaborative to ensure that we are able to support providers in doing good shared decision-making, or there's things that health plans can do too to help support providers in doing shared decision-making. It needs to occur at the provider-patient level, obviously, but even just training. There can be a requirement for your providers to get training, or just an encouragement. You know, you can have a group training where you do it all together. So when it comes to recommendations, for me, the biggest thing is how do we advocate for providing incentives for providers to do this, and educating patients about they should be asking for this information. So not a great answer to your question. Judy, I don't know if you have anything to add to that.
Yeah, I don't, but I agree. This is a thing that we need to figure out how to make work, and I think would make care better.
And unfortunately, there's not any good examples across the country of people who are doing this well, with the exception of Kaiser, but we know Kaiser is a very large health system, because Washington State is leading the way in a lot of ways on this work. So
it looks like we have another comment from Nan. She has her hand up.
I was just going to answer the question or give you an example. If you're in a patient, in a room with a patient. I attended the in-person shared decision-making workshop in January. It was very informative and highly recommend. But an example would be, a patient's cholesterol labs come back in Epic. And so at Kaiser WPMG, from the PMG standpoint, the tool itself uses, to calculate, for example, ASCVD risk, and then be able to use that tool based on all their history pull from Epic with the score, right? And then you're sitting in front of the patient and you're telling them the score. And then of course you're having a discussion around, this is your risk and this is the recommendation and why, and then documenting it. You can also code for it too. So there is a code for, saying I use shared decision making, and this is what we talked about, etc. Another one that's widely used at Kaiser is AFib. And so being able to pull up their data, all the labs, plug it into this tool immediately with a button for a chat score, and then have that conversation in the room. So those are some examples that might help you envision that.
Thank you. Yeah, that's exactly what we do. And I'm a residency program director. We teach our residents to do that with patients. I guess I'm trying to, I don't know what I'm struggling with. I think administrative burden of documenting this, if it's some other click boxes and then mandating that folks go to a course when we're already doing our kind of health stream modules after hours, like how do we, this is super important. I completely agree. But just how do we get there? So yeah, super important. I definitely want to state how much I value this, and think shared decision making is important.
I would just add really quick regarding the training. It's a 90-minute training, but you can start and stop. And that's what I hear from a lot of providers. They're like, oh, 90 minutes, that's a long time. But you can start and stop it and come back to it. And you get a little certificate at the end if you want. But one of the things we learned through the pilot that we did with ACPs is they got all their providers in a room at one time and walked through the training together. And then they were able to discuss, you know, how is this different from what I'm currently doing, or what are some ways that I could start to think about incorporating this into. But there's no right way. It's just you know, encouraging, you know, providers who really are still not 100% clear on what this is and how it impacts their patients and their own satisfaction too, that it improves that patient provider relationship. So we're just out here encouraging at this point in time. So any ideas for policies, or we appreciate that. And there's a link on the bottom on our shared decision-making webpage. There is a, if you want to sign up for alerts about activities coming up, whether it's, we do a lot of online ones or in person, go out to that page and sign up, and we'll add you to our listserv.
Thank you, Laura. I appreciate it, and excellent information. Next, we're gonna move back over to Shane from the center for talking about measuring primary care expenditure targets on a PMPM basis. So there you go. A pretty new slide.
Thanks. We're back into policy recommendation discussions here, and this one is a little bit unique in that this isn't one that was part of the original set that you voted to advance. And the reason for that is that we had lots of speakers, clearly today included, that we're trying to learn some best practices from as we advance this policy into the longer term. And one of the speakers was from Rhode Island, and they had raised that one of the lessons they learned is that it might be appropriate to look at a different statistic in the longer term. And because that transitioning to a different statistic, it takes some doing. We thought it would be helpful to bring forward a staff recommendation just to get it in front of everyone early in the process. So it's at least on the back burner, if nothing else. It's at least on a burner. So by way of issue and background, when the state established the primary care expenditure target of 12%, there was definitely some reliance on the experience of other states. Rhode Island, which I just mentioned, was included. They had really led with this policy nationally, and that's where they started. So setting at 12%, and as you recall, they had some quite good success in their state with this policy. We know that a 12% expenditure target will unambiguously drive investments in primary care based off of the early analysis. You're less than halfway there in aggregate across all of the different payers. So like I said, unambiguously, a 12% expenditure target will drive investments in primary care. It is consistent with the statutory direction, but it may not be the best target to use indefinitely. The reason for that is that changes in expenditure in other service categories, like hospitals, would dictate the level of primary care investment needed, completely independent of any actual need of primary care practices. If you go to the next slide, please. Thanks. So, and as I mentioned previously, you had the opportunity to hear from experts in Rhode Island, and based off of their lessons learned, they were considering transitioning to a different unit of measurement for their primary care expenditure target. If you go to the next slide. All right, so we'll walk through this stepwise here. On the next slide, some of the options to mitigate the risk of having a target that is somewhat detached from any measurement of actual need for primary care. In the longer term, Washington could consider transitioning to a per member per month target or to a per capita expenditure target. So that would be the amount of primary care dollars divided by the total number of people covered, multiplied by the number of months that are covered. When using these types of statistics, the amount of primary care investment needed to achieve the target, it wouldn't be inappropriately influenced by changes in price and utilization of other services. And we'll have a general example for this in the upcoming slides here. You go ahead and go to the next one. Great, thanks. So some of the analysis of the policy, unlike some of the other policies, there isn't an evidence base for this change. It's really based off of a logic model on what we learned from Rhode Island. And on the next slide. In terms of the impact, using a PMPM or per capita measure would, one, mean that primary care spending targets are not determined in relationship to non-primary care expenditures. And it would also importantly allow primary care expenditure targets to be tailored to meet the actual needs of primary care instead of indirectly estimating them in relationship to other spending. And next slide. And this slide is really designed to illustrate that concept. So you can see the first graphic here that has the total spend of $100 under the 12% primary care expenditure target. It's obviously $12 would be going towards primary care. Then if you had a major innovation or a price control that is independent of primary care and it drives down total spending, that would actually change what you were what the target for investing in primary care would be. So in this example, that innovation or price control drives total expenditures down to $91, and then your target investment in primary care is $11 from the 12. This is a really simple way of illustrating this concept, but it does result in a reduction in the level of primary care investment independent of the need of primary care services or independent of the cost of providing those services. So ideally, your investment targets would consider the needs for primary care services and consider the cost of providing those services. So again, this is just a very simple example that's illustrating how using a target that's predicated on the percent of total care expenditures, it could result in changes in targeted investment in primary care that just aren't appropriate, that they may not, you could result in having a target that's not investing enough in primary care, for example. Now, I want to reiterate that this is really a very forward-looking proposal. This might be something that you look at implementing, maybe not as a year one thing, but a future year policy. But I think it really is important to acknowledge now, because you can see off the bat, we know where we're at in Washington, around that 5 to 6% approximately. The 12% expenditure target will unambiguously drive investment in primary care. However, we know that having an index to total spend has the risk of having really a spurious relationship between primary care investments and actual need in primary care investment. So again, we're just raising this issue based off of lessons learned from other states. We want to highlight this as what would likely be a little bit of a longer term issue. It may not be a priority in the shorter term, but this was really an opportunity for us to get this in front of you as part of the suite of considerations for this this general policy moving forward. If you could go to the next slide, please. So in terms of the effectiveness of the policy, transitioning to a PMPM or a per capita target would be an effective solution for the specific challenges we were just talking about, where the relationship between primary care investment and price changes and utilization changes and other services aren't necessarily correlated in a way that's meaningful on the longer term. Next slide, please. Feasibility. This is potentially another reason why this might be a little bit of a longer term recommendation, but if you were to try and change the unit of measurement for the primary care expenditure target, politically, I think we're all here because there was a legislative mandate that codifies the current statistic for primary care expenditures. Changing statute to accommodate this, it's unclear if there would be support. Administratively, I think it's not a trivial lift to figure out what a more appropriate per member per month or a per capita expenditure target for primary care would be. You would likely want to inform that by assessing provider costs and accounting for population health status and also clinical best practice. And again, that's not a trivial lift. And then actual measurement of using a PMPM on or a per capita target, it wouldn't necessarily be more administratively burdensome than your current process of measurement using the percentage of total expenditures. And there is some infrastructure in place for the data collection and the calculation. So it's a little bit of a mixed bag where there are certainly some initial administrative burdens for identifying the appropriate targets, and I don't think they're trivial. And you also have infrastructure that would allow for transition from status quo to future state under a different statistic. So a little bit of a mixed bag. If you could go to the next slide, please. Thanks very much. So again, here we're just teeing up the recommendation. These, I think you would definitely want to treat as a set. It says vote, we're not voting. This is to tee up an option for the June vote. But our straw model, so just giving you something to react to based off of the lessons learned from Rhode Island. The Healthcare Cost Transparency Board should evaluate the feasibility and appropriateness of a primary care expenditure target based on aggregate per capita or PMPM expenditures instead of an aggregate expenditure ratio of 12%. And then the second piece of this, if the cost board determines a PMPM or per capita target is feasible and desirable and targets are identified, they should make that recommendation to the legislature to replace what's currently codified. So to replace the 12% primary care expenditure target with the revised PM or per capita target. So again, this is something that staff are bringing forward based off of what we've learned from other states since the vote where you originally identified some priority policy areas that support achieving the 12%. But we wanted to get it in front of you and include it as part of the documented set that you're looking at. But with that, I'd open it up. Does anyone have any questions or reaction to the proposal? I know the nuances of the math is less exciting than patient engagement, but it's still worthy.
Changes, DC. I mean, I certainly see the wisdom in looking at a model that could stand the test of time. And this makes total sense to me. I don't have any questions about it.
Yeah, thanks for that feedback.
It looks like
Yeah,
one hand raised. David?
Shane, I appreciate the question. I'll just tell you some of my initial thoughts. I think both the percentage and the PMPM have their imperfections. I think they're both, they both need to have an anchor point where the baseline and the out year are measured on the same terms. Where I'm contemplating the possible downside of a PMPM is, let's say that specialty care expenditures on a per capita basis are going up 15% a year, and primary care expenditures are going up 10% a year. I don't know that that means we're investing more in primary care so much as have a cost trend and balance. So I don't know if that's the right way to think about it, but that's where my mind is right now.
That's a really good question. I'm glad you raised that. I think the way we're thinking about it would be more along the lines of a dollar amount. So, if you have a patient population on average that needs 3 primary care visits per year and XYZ services in an ideal state, and those services cost providers to provide plus margin, you know, a certain amount of dollars, you could turn that into a per capita expenditure target, that's when you start to pull away from, you know, the percentage change movements and start to ground it in what does the population actually need versus how are trends moving, which is a little bit of a different question, and I think aligned with the challenge that you're raising.
Got it. Thanks.
Yeah, absolutely. And sorry, I don't think I can see all of the hands. I know Judy, you were starting to make a comment.
No, I just came on video to bring up yes, encourage discussion.
Oh, thank you. Tony?
There's a hand.
Yeah, thanks. You know, it seems to me that the 12% is kind of our target spend, and the per member per month is just acknowledging we need to get into a way fee for service and non-claims based data. And this is kind of a mechanism to achieve that 12%. And then we would revise if we implement it to go back. So I think we're saying the same thing, but just the way I'm framing my thoughts on it.
Okay. Yeah. Any other comments or feedback?
I don't see any other hands, Shane.
All right. Well, thanks for giving us the opportunity to walk through that. I know it's a little bit off the beaten path of what you had originally voted on, but again, we thought it was important to raise. So thank you.
Thank you, Shane, and thank you everyone for participating in today's discussion. The recording and summary of this meeting is going to be posted shortly on our website, and our next meeting is Thursday, May 30th. As earlier stated, we'll discuss 3 more options, and it should be good. So have a great afternoon, everyone. Thank you.
Thanks, everybody. Bye.